let's get started by going around the table, and we'll introduce ourselves as we go. I'm Dr. Kathy Gloyd, President of Elevate DVM. Joyce?
I'm Joyce Logan with Zoetis. I'm the medical support for our chronic pain products, dogs and cats.
Okay. Tammy?
Tammy Grubb at Washington State University, and also a consultant with pain management and private practice.
Right.
Ralph Harvey, anesthesiologist, University of Tennessee for many years, and now chair of Veterinary Advisory Group for BioTraceIT Corporation.
Okay. Margaret?
Margaret Gruen, behaviorist, veterinary behaviorist, and at North Carolina State University.
Great. And Mike?
Mike Petty, and I am a private practitioner, and I own a pain management clinic in Michigan.
Joining us now is Dr. Ross Palmer from Colorado State University, where he is professor of orthopedic surgery, and we're delighted to have him to join us right now when we start talking about acute pain, where we know that we are causing the pain for an animal in a surgical procedure. And Ross, I'd like your perspective of how you measure or think about pain in an animal that's going to undergo an orthopedic procedure.
I think there's really two components to that. I mean, oftentimes, they present for pain. That's why they're having this procedure, and that can be acute, or it can be chronic, or sometimes chronic that's been exacerbated by an acute injury. But then there's also the surgical pain itself, and as we oftentimes talk about, it's a little bit anthropomorphizing the experience of just thinking about, if this were you, would this be painful, and how painful would it be? And not waiting to see some dramatic response from the patient, but just recognizing that surgical procedures are painful. Right? Orthopedic disease is oftentimes painful. Certainly orthopedic injury, everybody gets that, that's painful. So we just assume it, we know it, we accept it, and are proactive as we can be.
Well, as you're talking about these conditions that are painful, and we all know they are, I keep thinking about the fear, anxiety, stress portion of that, and looking at it through their eyes, like you say. If someone were to take us to a hospital and we'd never been in one before, and it smells weird and all these sounds and beeps are going off and the whole experience is strange, and then they cut on us, right, what that feels like for the animal. Going back to that integration of the management of the fear as well as the pain. And Joyce, I think you had a comment about that, about if we don't manage that fear, what long-term outcome is.
Well, exactly that, which is, we think about the acute pain and the surgery, and they come in for a surgical procedure. And if we don't do anything or don't address that, as we talk about fear and anxiety, and I'll let the experts comment on this, are we then, of course, setting them up for ramping up and spiraling more into chronic maladaptive pain and distress, and really causing problems down the road that we could have cut off early on by addressing the pain before it happened.
Or addressing the fear.
Oh, well, addressing the fear and the pain, yeah.
Right, exactly. And so when you have a patient that comes in, how do you evaluate this animal? And I mean, do you just assume it's going to be massive pain because it's an orthopedic procedure and that you have to treat everything? And then how do you go about it? And how long do you keep going before you get out of that cycle?
The devil is in the details, right? It is that individual patient assessment. And so certain injuries, certain diseases have a degree of pain that you can anticipate for that. Certain surgical procedures, depending upon their complexity and their invasiveness, have a certain amount of pain that you can anticipate. But I think it is also important to evaluate their level of anxiety. And much like pain, I think we can assume patients have anxiety, okay? That there are different probably levels of that anxiety, but I think sometimes, and I would include myself in this, is sometimes we make the mistake of assuming that the gregarious, social, young, interactive dog isn't anxious. We know better. In the exact same circumstance, if we look at it through the lens of the patient, You walk into a hospital environment surrounded by caregivers that aren't your species. They don't speak your language. They don't explain what they're about to do to you. That's stressful. And we just accept that that is the case. And I think our awareness is changing so rapidly over time about that recognition of the fear and the anxiety and the stress.
Can I add to that? You know, I've been practicing now 40 years, and when I got out of school, there were very little options that we had for pain management. We had morphine and local anesthetics and ketamine, although it really wasn't used that much for pain at that point. And, you know, one of the things I noticed was that we would have these puppies that came in for vaccines, and they were always so happy to see us and licking our face and just wagging their tail and happy to be there. And then we'd neuter and spay them, and they'd come back 6 months later for their annual vaccines, and they didn't want to be there. And, you know, as pain management has gotten better, you know, first with the introduction of Rimadyl in 1996, and then the other NSAIDs and the ability to more advanced opioid use, now these dogs, most of them are coming back and are very happy to be there. They don't have that pain experience that has combined with the fear of, you know, being there. And, you know, there's a really good example from human medicine, and I can't remember the year it was published, but it was published in Lancet, and they did circumcisions on baby boys, and half of them got EMLA cream and half of them did not. 6 months later, when they came back for vaccines, they were screaming and crying if they had not gotten the EMLA cream. If they did, they took it. And, you know, again, I think that's a combination of both fear of the pain and the pain itself. You know, there's probably some plastic changes to the spinal cord that made the vaccine hurt more, but also it was ramped up by they know something's going to happen.
So much of our intervention for pain in the past, and even currently, has dealt with the somatic aspect of pain and not so much on the anxiety and stress and fear. And that is changing. Ronald Melzack, who's of course best known for Melzack and Wall gate theory of pain many decades ago, Ronald Melzack described a discriminative aspect of pain as opposed to the affect of pain. The discriminative aspect being more somatic. It's the fast fiber transmission, tells us to take our hand off the stove. And the affect of pain, not how pain feels, but how it makes us feel, is more of the suffering component, more of what might be connected with what we consider the emotional aspect of pain. And as we look at different therapeutic modalities and different options to intervene, we're now seeing an obligation to address that suffering component of pain, to address the anxiety, to address the fear, to address the emotional aspect of pain. And it leads us to consider using other modalities that we may not have considered in the past. And in fact, some of our assessments for pain in the past have only dealt with the discriminative aspect of pain, the somatic aspect, and not dealt with the emotional aspect. So we have some very good studies, for instance, that might show a lack of efficacy of behavior-modifying drugs or anxiolytics or mood-elevating drugs in assessment of pain, because those assessment tools that have been used only look at the discriminative aspect of pain and not the affect of pain, not the suffering component, not the anxiety component. So as we recognize the importance of this dimension of pain, the suffering of pain, which may be more important than the somatic aspect, we now have an opportunity to address the anxiety.
Yeah, I think that really becomes part of when we talk about multimodal therapy, that becomes a part of it. It's not just the different drugs that we use, it's addressing that emotional, affective piece. And I do think that we can assume that animals come in and are anxious because they've lost choice and control, which are the two biggest things that we can provide for welfare. So if we can give animals opportunities for choice and control, we can decrease some of that stress. Even if it's giving a Heidi box to a cat, you'll see a lot of them choose to come out and sit where they can see, but they have a choice and they make a decision about it. And so giving them that can really decrease anxiety. And I think Ross's point about animals coming in with various levels of anxiety is a really important one too, because as a behaviorist, I think of anxiety as these anxiety disorders. And all of the animals will come in on some spectrum of anxiety about what's happening, why is this happening, where's my people? But animals who come in with chronic anxiety are even at a bigger disadvantage because they have less coping ability. I mean, if you think about people with chronic anxiety, they have tension headaches, right? They might have other disorders like irritable bowel syndrome. I mean, things that we know are associated or exacerbated by stress and fear. So those animals are even at a greater disadvantage, and we really need to think carefully about those ones too. But I think it's really, your point is a really good one, that we should assume not just the anxious animals, all of them coming in will have some fear and anxiety about what's going on because they've lost that choice and control.
What do you do to give a dog back choice and control? So you talked about a hidey box for a cat. That's something easy. Doing something that's comfortable for a kitty and their carrier and that type of thing. What are the types of things you should be doing for every dog that walks in the clinic that give them choice and control? I hadn't thought of it that way.
Well, I think a lot of it is just time to approach you, taking that time to become, I thought what you said was so great, become their friend before you're their doctor. So taking that time, giving them the chance to come near you. If you have to do a treatment to a dog who's in a cage, if you can set it up so that you can do it without coming right at them, you can be over here and they can decide if they want to come over to you. So any of those places where we can think about giving them a choice in their behavior will help.
Okay. I think about how often we're so pressed for time that what's a typical thing that a lot of veterinarians do is the animal comes in, and the first thing we do, we take it to the back, right? And I can't think of anything that gives them less control, right? Because they sit in a waiting room that is filled with smells and sounds and all of these things, and then a stranger walks up, puts a leash on them, and takes them to a place that they don't know where they're going, they don't know what's going to happen, and yet this is commonplace. I don't like the back and away from their person, which is the most important thing. I mean, how many times do you see this? And the dog is looking back over its shoulder at the owner because they don't know where they are. And yet we took that for normal behavior for so many years, and I think a lot of people still do, instead of making them a safe place in our hospital. So what do you do in your hospital that makes for this safe place?
I think it's always difficult, and there's some things that will be stressful, and it is a hospital. All of us are, I don't know about all of us, I shouldn't say that I'm stressed if I have to be in a hospital. So doing as much as we can with the owner, so more things in the exam room, and it's easier as you get older than as a new graduate because you're a little bit unsure, so part of it is the doctor as well, but as many things as we can in the exam room, as many things as we can on the patient's level, instead of up on a table where it's scary. Like I do acupuncture in our practice, and I do that on the floor. Ross was showing us kitty exams yesterday with the kitty in his lap on the floor. So being on their level, I think, helps a lot. And better use of anxiolytics before they come to the clinic. We know they're stressful, and as everybody has said, and probably some of us take anxiolytics before we go to a hospital, and realizing that that's okay. That's just a normal thing. And decreasing that fear, anxiety, and stress, and also treating their pain before they come to the hospital. If you know a dog has osteoarthritis, give it its NSAIDs that morning, for heaven's sake, so that we're trying to treat both the pain and the fear, anxiety, and stress. So a lot of it starts before that pet comes to the hospital.
This may be a good time to interject that these strategies and these approaches are very, very cost effective, of course.
Yes, agreed.
But people don't
the
think
net
that.
effect,
They think
that's
it's going to
right.
take so much longer.
That's why we bring it up, because it's
Yeah.
cost effective, it's time effective, it reduces the number of personnel involved to perform a procedure or obtain radiographs or do something to the animal. If we do these things to relieve their stress, offer them rewards also.
Right.
It might be a cheese spray, it might be the churro rewards or some other
Right.
reward for the animal's good behavior, something that's not only distraction, but it's a positive reinforcement for the whole experience, because they are associative learners, I think, as you commented yesterday. They learn that we're okay, that it's okay, and something's being done, but it's not the thing that's primary in their mind.
Right.
And those strategies are time effective and have shown to be very cost effective and reduce incidence of serious injuries to our patients as well as to our personnel.
Right, and to tag on to that, escalating it, exactly what you're describing, going on to sedation. Don't be afraid to sedate an animal in your practice, especially with a drug that is also an anxiolytic, like dexmedetomidine has been shown to decrease cortisol release. So
In humans as well as
in humans as well
patients.
as animals. So sedate them. Don't let it escalate to the point that it's dangerous for that animal because it's so stressed and dangerous, like you said, to your personnel. So it's like you said, that's cost effective and it's just the right thing to do. There's no reason to have a patient in your hospital that stressed out.
And not only sedate them to do a procedure, send them home with an anxiolytic and have them come back.
If the owner can do that.
And most people can. And I mean, they may not come back that day, but they always come back and they're always grateful. And I say to them, we don't want to fight with your dog or your cat, and you don't want to see it, and the dog or cat doesn't want to do it. So why are we struggling to get a blood sample? We're going to send you home. You're going to give this medication, and you're going to, 90 minutes before you come in for your next appointment, and we'll do it then. And everyone's happy. I don't think I've ever had a person get angry or not come back or whatever. They appreciate that.
And we can allow that gentle level of sedation and anxiolysis to persist when we don't need to reverse the effect of those medications. We'd like to avoid reversal of that beneficial level of sedation and anxiolysis as we can to take advantage of that for the rest of the time that animal is with us and then as they make the transition to going home.
Oh, and I think, walking through the experience at the level of the animal, the dog or the cat, just starting from the waiting room and walking through what does an exam look like? Where do we go? How can we improve the flow? How can we not go through so many doors or have people come in and out? And I think that taking that pet perspective, Ross talks about a lot, that pet perspective can really be eye-opening. What are the smells and sounds that they're being exposed to, so that we can address those at each spot. And I also think about when we have to do something painful, sedation and anxiolytics are great. I also think about the time that we spend is like putting money into a bank. And so when we have to make a little withdrawal, we've got money in there. But if we haven't put any money in there, then there's nothing to draw on. So
Yeah, that's really
And didn't Temple? Oh, I'm sorry. Go ahead.
Well, I was just going to talk about this, the interplay between the pharmaceutical management, but then also those creature comforts. Once again, and we all know this. I mean, think of the last time you had a hospital experience. Certainly, if there was pain involved, you had the pain treated. But what else is there was that caregiver who brought you a warm towel, a warm blanket, a warm, soothing voice, calm touch, took time with you. It's
let you sleep through the night.
Let you sleep, right. Those are all essential. And so the interplay between the two, I think, is important. And then trying to create a hospital culture then that's the norm. Yeah. And I think that's the challenge that many practices, and especially the larger the practice, I think the bigger the challenge. But,
academics, that's why I'm looking at you, because I think for what Mike does, that he has total control over what's going on in his hospital.
Yep.
When you are in an academic institution, and that pet is invariably taken away from the owner, and that waiting room is invariably chaos. How do you, have you instituted this, and does it work?
Yeah,
how do you do it on a large scale?
I would love to tell you that I do it perfectly, and that would be a lie. Okay, I don't. And I think again, this is where awareness is important, is beginning to see what you do individually and beginning to see what you do as a team. I'm as guilty as anybody of doing my exams sometimes away from the pet owner. And I think, again, it's an awareness of how is that being done. There's all kinds of levels of stress that can be associated with that. I do think there are instances where an owner actually can escalate the stress of something like an orthopedic exam because they're a bit preoccupied by, well, my dog's not being quite obedient, or, oh, you're not doing this, or, oh, did you hurt him? Or there's a level of stress that the owner takes on that then can transmit to the dog. So sometimes I do believe that actually doing an exam away from the owner can be helpful. There's different ways to do that. Sometimes it's as simple as explaining that to the owner and asking them to leave the room so that we don't have to. Okay, so we stay where we are. Other times I will take the dog to a different room, but again, like Margaret says, that awareness of what is that transit going to be like? What environments are you going to take them through to get from point A to point B? And then what does point B look, feel, smell like is really important. And again, in a teaching hospital environment, there's a lot of things going on. So finding those secret enclaves where you can disappear and just have time, just you and the patient. And it is amazing the difference that can make.
And I think that's a place where I think the species is really important. I mean, dogs, it is
Very
important
good
for
point.
dogs. It is infinitely more important for cats.